Welcome, everybody. It is so nice to see so many people interested in this topic. I'm Monica Baer. I am the Disability Services Community Manager at Dane County and co-chair the CSC with Beth. And when she talked about us having received a grant 3 years ago, one of the things that DHS was particularly interested in was reducing the of days that adults with dementia or intellectual disabilities spend at Winnebago and Mendota, which are referred to as IMDs, and finding kind of creative ways, sustainable ways to reduce those admissions. And this sort of shows the trend. 2019 would have been the start of our work after a pretty significant spike up. IMD days in the last couple of years are not at historic norms, but they have certainly stabilized and aren't increasing at the pace beforehand. And similarly, folks with dementia, there's still a few bumps, but ultimately not near historic peaks. So we're doing a little bit better with folks with dementia. IMDs for folks with intellectual disabilities, we've stabilized, but still have a ways to go in reducing those. The other piece of kind of a core belief of the group is that people being supported, in their home communities as close to home as possible. And we are seeing an upward trend, unfortunately, of Dane County citizens with IDD and dementia who experience behavioral crisis living out of county. And as a group, we try to have a lot of conversations about how we might be able to reduce those. But today, we're going to hear from some who have been partners in our stabilization efforts. And since there's such a big group on the Zoom today, just know that the session's being recorded and can go back and listen or share it with colleagues who aren't here today. Michael, who the real Michael Truman, will be keeping everybody on mute. If you've got questions, we're going to take them at the end, and so we ask that people put those in the chat. It is being monitored, and we will try to capture as many questions as we have time for. And also, when all is done, slides and materials will be shared. And for those of you who would like a certificate of attendance or need it for your social work continuing education requirements, a certificate will be provided in exchange for you completing an evaluation and giving us a little bit of feedback. So to get to the reason that you're all here today, I just wanted to say, kind of the word collaborative is really important. We're a collaborative stabilization coalition. And today the collaborations that we're focusing in on are ways that over the last couple of years we've tried to integrate IDD and dementia-informed perspectives into some of the new behavioral health initiatives that are being developed and expanded here in Dane County. So I'm going to turn it over first to Sarah Shimko and Leslie Fox. Sarah being the one who oversees the mental health officers for the Madison Police Department, and Leslie, who works at the Sheriff's Office in a similar initiative, and they'll give a little bit of overview about how they have partnered crisis response. Thanks, Sarah and Leslie.
Thank you. Just wanted to clarify that you can see the slideshow. All right. So bear with us. This is the first time Leslie and I are presenting together, but I appreciate the partnership, and I do appreciate the partnership of the committee and all the work everybody's done, and also for everybody who's here today to continue and broaden those partnerships. So we're just going to give you a quick overview of both of our programs and basically spend maybe the first 8 or 10 minutes talking about each of our programs, and then we'll go into talking about a very basic overview on some tidbits of how we can improve crisis response from the partnership with law enforcement before the crisis happens, during the crisis, and then after, just to give you something to munch on, so then maybe you can follow up with us at a later time if you ever need to. So like was said before, Monica, thank you. I've been the sergeant for the mental health unit with Madison Police Department for the last 4 or so years. I've been with the department for about 16. I do have some previous experience as a mental health provider, mostly in the communities and schools. So I have the pleasure of being able to put those two passions together. So, you know, ultimately, law enforcement comes into play in a crisis when it comes to dangerousness, people getting to over the threshold of the capabilities of providers to keep things safe. So that's when kind of we get involved in that other piece of our role is then if somebody is experiencing that crisis and is running the risk of having to go to a more restrictive environment, if they don't want to do so voluntarily, statutorily, police are responsible for facilitating that and helping in that decision-making process. So in terms of an overview of MPD's programming, we have a commitment and have had a longstanding commitment to community partnerships and also making sure that our officers are trained well to be able to identify people in crisis. So we spend a lot of time in our in-house academy training officers just at that basic level, so when they come out of the academy they can see that they have somebody experiencing a crisis. They're equipped with some techniques of how to de-escalate in specialized situations, and then also to reach best possible resolutions by partnering with community agencies, specialists to help identify how to best stabilize and keep people safe. So that's our basic level, and I always think about it as a triangle. The foundation is our patrol officers, so we expect all of our patrol officers to have that level of service and expertise. And then we have also a large group, actually, of mental health liaison officers. So they are, we've gone from having 5 in the beginning, back in 2004, to now this year we are topping out at 50. So we have 50 officers within our ranks, so our regular patrol officers, who have volunteered to say, I want to learn more and I want to serve more specifically in this area. And so they receive additional information, they have additional responsibilities within their districts, and team well with our full-time mental health officers. So then, like I said, that's kind of that middle tier of our triangle. And then that top tier is the full-time mental health officer group, and they collaborate very specifically also and intentionally with our embedded crisis workers. So we have 6 districts at Madison Police Department. So we have 6 full-time mental health officers, 1 for each district. And then we have 3 embedded crisis workers from Journey Mental Health, who they are assigned to basically cover and be responsible for 2 districts and kind of work with those officers, liaisons, full-time mental health officers, but they're able to for sure go department-wide and city-wide to support as needed. So I just, wanted to give an overview of the philosophy of the mental health department or unit within the Madison Police Department, and also reassure the community that yes, it would be great if we could have a clinician and a mental health officer on each call, but we can't provide that level of specialized response. But we are ensuring that we're trying to do our best to meet the needs at each level, and then fold in the additional higher levels as we're able to on each call. So That's enough from my standpoint. I think I'm going to hand it over to Leslie, let her speak to her department's programming, and then we'll go through some additional slides.
Thanks, Sarah. I'm Leslie Fox with the Dane County Sheriff's Office. I'm one of the community deputies. I've been one of the community deputies for just about 20 years, and on the department, I'm in my 24th year. So things have vastly changed in my role over the past 20 years. And like Sarah said, in the Law Enforcement Academy, all officers get a basic level of crisis management. Then many of our deputies, everyone starts out in the jail. A lot of them are able to get some continuing training on crisis intervention training, and I've had that myself out in the field. One thing that we've been doing a better job at in the past few years is continuing some of that training at our in-service. And now also we have something called a mini academy. So as deputies transition from the jail out to patrol duties, they go through some additional training, and I am teaching in that myself along with some of my partners, some additional crisis management, mental health overview, and I have specifically included information on dementia and IDD, so we can have a better informed approach as deputies transition to patrol of how to, help in a crisis situation, especially with vulnerable populations. So we've really tried to make an effort to incorporate more those types of trainings at our department. And so basically, we do not have a specific mental health unit, but we have 8 community deputies with the county right now. So there's 4 on the west side, 4 on the east side for the whole county. And we have a number of different roles. That would be a whole PowerPoint in and of itself, but especially the last several years plus, as we've been seeing an increase of mental health related calls, and a lot specifically with the population we're talking about today, IDD and dementia, just naturally our role has been directed more towards crisis management, crisis response, for those folks in our community that we're trying to help out. And so the community deputies have really taken on that role. And now, similar to Madison Police Department, within the last few years, we also have embedded mental health workers with us as well, which has really just been such a great collaboration with Journey Mental Health, of having those embedded mental health workers able to co-respond with us, help us with preventative follow-up work. I'm really big on as much proactive work as we can possibly do. So if that crisis situation does occur, we know how to appropriately respond. And Sarah and I will talk a little bit more about the steps we take prior to a crisis to help achieve that. But I can't talk enough about that collaboration with our embedded workers. And additionally, we've also been working more with our jail mental health staff with WellPath. So as people, unfortunately, if it does go the route where they go from the community to jail for a period of time and then back to the community, we can help just with the continuity of care and making sure everybody's kind of on board with what the needs are for this person as they're in jail and then as they come back out into the community. And that's something many years ago when I first started, we really weren't having that communication. So just opening those lines of communication up a little better, I think has worked out well for our community too. So that's kind of a basic overview. It's patrol, community deputies, and that's it. Then supervisors and above that, we don't have the specific mental health unit, but just know that the community deputies have taken on that role and are able to provide that service as well.
Yeah, thank you, Leslie. And I think, you brought some things up that I think those collaborations, and one thing I do want to indicate is even though different jurisdictions have different programming, we also do our best to, if a community member comes to me, for instance, and is asking about a loved one who lives in a different jurisdiction, we do our best to reach out then, and Leslie's at the top of my list. She's my go-to person, and I know she'll make it happen if I've got someone who lives in the county. And so, and also mitigating any unneeded law enforcement or criminal justice connections for citizens. So we're always working on those pieces and are doing as well as we can to make sure that the outcomes fit and are suitable for individuals as much as possible. So there's a lot of communication behind the scenes to try to meet the needs of the community, because we do have some silos that we're continuing to work through. So yeah, this first slide, we're just kind of talking about things that we can do together when people think that a loved one or someone they work with might have an occasion that would require law enforcement to assist. So before a crisis occurs, anybody who's supporting a loved one, you want to make sure that you reach out to the county designated crisis service agency in Dane County. That's going to be Journey Mental Health Emergency Services Unit. And if anybody's ever, has questions, feel free to reach out. I'm happy to help people navigate how to get that done. Because Journey Mental Health has crisis plans, just like the police department does, and we formulate them and kind of put them together differently for the different needs of the various, team members who end up responding to these things. So that's a good start to make sure that the Journey ESU has that information on file, because they are really the county point at which they're able to have all that information. So then if a police officer is in contact or a deputy is in contact with a person in crisis, we can contact Journey Mental Health and see how best to serve somebody and who they're connected with and where to get them to be safe and taken care of, to be stabilized. And then at this, additionally, it's very important to, just one second. I'm in a room with a light source. Hey, Leslie, why don't you take over for a moment? Oh, there we go.
Sure. Okay, got it.
Sorry about that. Yeah, I'm in a room that has lights that automatically go off. So we'll see how many times that happens. But also, you want to make sure to contact your local law enforcement agency, because we put, and we'll talk about the bulletins that we can create to assist officers and deputies in responding. And we can also set up meetings with providers to ensure good communication networks to know who we should contact when somebody is in crisis, and also to talk with teams about how we've seen it be successful and things we want to make sure to plan for. And then, we'll develop those police response plans or bulletins. We can determine if it would be advisable to put a safety alert on an address and or a phone number. And so that when officers or deputies are being dispatched to a scene, they would automatically get information that would let them know some specifics about safety issues, or that there are safety bulletins on file for the person. Maybe meet with the person individually and or their support providers, so we can start building those relationships and that trust. Rather than trying to, piece that together in the middle of a crisis. It's nice to get to know each other beforehand. And then, if people are interested, we can do safety audits of the residents where people live, because from a police or law enforcement lens, we might see things that community members might not see. And we can just offer suggestions, but please, be informed that is it's a service we provide, and it's totally up to the community as to whether they're comfortable with that or want that. And then also a big piece is to make sure that the direct care staff are well prepared and well supported, so that they know when they have a crisis with somebody that they're caring for, that they know and know how to predict what steps to take so that they can feel confident about their response. So making sure that they understand the individual's care plan and that they're following it, that they know what their crisis plan is, and they know what information that they would need to share with law enforcement. And a big piece of what we do in law enforcement is scenario training. You actually put people through that experience, because how we respond in an emergency situation is very different from when we're able to really think clearly. So those are some of the things we ask for to be done prior to a crisis. And then Leslie's going to talk to you about, why don't you talk about the bulletins?
Sure. And I know we're down to just a few more minutes left, but this is an example of a safety plan or bulletin that we can put together for somebody. Madison Police Department, Dane County Sheriff's Office uses this exact same template, and it can change depending on the situation, but you can definitely see we like to get all of the appropriate contacts on the left-hand side there, a little bit about the person and what they might be living with, diagnosis, commitment status, and who do we need to call in the moment. And then the right-hand side, how do we develop that quick rapport with them to try to keep them de-escalated, and definitely not escalated, when they're dysregulated. Triggers, things to stay away from, not to talk about, and just general negotiating tactics or other pertinent information. That might be just good information, like when they're dysregulated, they might need to go for a walk, or they might need, you might want to talk about music or art that they'd like to do. So just different things that we can very quickly pick up on and start to talk to them about. And we have the ability to put that in our records management system, and also through dispatch, possibly put an alert on there that a safety plan does exist. So responding deputies and officers know to look for that. And then during a crisis, it's best to have this information ahead of time if we can, but we will be asking questions like who else is in the residence? Are there any weapons present? It's general safety type information that we ask a lot at most calls. History of violence, particularly towards police. We might ask the caretaker or the person that's with them to step away or move to a safe distance until we can have the situation calm down. And if it's something where we don't have the response plan ahead of time, we might ask for that. Do you have a response plan or a team, or who's the emergency contact information that we might be able to utilize on scene there? And then if it goes to a transport to the hospital, we're gonna maybe ask for someone to go with us or identify a support person that would be appropriate in this situation to go along as well, depending on what the disposition ends up being.
And we recognize that, it's not always possible, but at a minimum, it's just nice to have somebody there, at the hospital if possible to answer questions. But at a minimum, it's really necessary for us to at least have a phone number for the decision maker, so we can make sure that we're advocating for the best disposition. So then after the crisis, really thinking about, okay, what went well? How can we improve also? One of the things that I really advocate for with care providers specifically, and especially with the different levels of providers and different responsibilities, making sure that you realize that there's the ability to get police reports. And what is in police reports is often different from what might be in a write-up from a direct care provider. It's not because anybody's, being untruthful. It's just different vantage points, different points of view. And all that information is really important. So I always like to make sure people know, and you contact the open records, the records department from our department, and Leslie can answer those questions as far as her department. Also looking and reviewing those safety plans. As humans, we all, grow and change, and we learn from each crisis and interaction. So making sure we're modifying those safety plans, and then continue to work with support providers and law enforcement to continue to have those plans evolve and that communication continue to build. And so anything else from your vantage point, Leslie? I think
our records will, records department, you can go through our website, www.danesheriff.com, and follow the directions there. And I know we're out of time, but I just wanted to also add, I have revamped several safety plans. That's just inevitable, as Sarah said, as people grow or things change. And also just know I've been on a lot of team meetings to help support the individuals in our community, and also proactive home visits when they're having a good day. and to build that rapport then when they're not in a crisis moment. And that is really helpful during an actual crisis, because they already recognize the uniform and maybe the deputies or the officers responding, and it really can help just de-escalate pretty quickly if we're lucky. So thank you.
Absolutely. Yeah, thank you all for being here, and thanks for the time for us to be able to speak with you today.
Great. Thank you so much, Leslie and Sarah. We really do appreciate you taking the time to speak with us. It's so helpful to hear a little bit more from behind the scenes as to how you guys help in our crisis situations. Excuse me. So next, speaking of crisis, and Sarah referred to connecting with Journey Mental Health Center, we are fortunate to have Teresa Bednarik, who's the Emergency Services Unit Manager with Journey, along with Sarah Hendrickson, who helps oversee the embedded crisis workers, along with the new CARES program that's piloting in the city of Madison, along with Jay Stedman, who's the Assistant Chief with the Madison Fire Department, who is also part of the CARES team. So really excited to hear about your roles in crisis and sort of some of this new CARES model that's been going on in the city. So thank you for being here.
So hi, I'm Teresa Bednarik, and I have been with Journey about coming on 12 years next month. And my co-manager, Sarah Hendrickson, and I try to see if we can get the best response for the situation. And I think if we kind of take a look at, I think what is most challenging is what exactly constitutes a crisis. And I know that that's one of Beth's original slides held a definition of crisis. And, we each have our own crisis. I mean, it can be if I'm cooking dinner and suddenly I just spilled the entire pot. I mean, that's a crisis right there for me, obviously minor. But we get a lot of phone calls, roughly around 3,200 or so every month. And those can vary quite widely. So Tracy might want to have the next slide. And so, we've got a lot of challenges, and in thinking about this, I think that, you probably all have been at various trainings or conversations about the impact of the past 2 years of COVID. And not to dwell on that, but I think where it impacts all of us is that sometimes the responses that we might have used before are not quite as readily available. We work with people who are accustomed to a face-to-face interaction, or to go out in the community in more regular intervals. So people are feeling more isolated. We have some financial instability, housing insecurity, food insecurity, happening regardless of whether a person is in the system of the IDD and dementia system. I think county-wide we are experiencing some unique challenges because of our ability to interface as providers. I know a lot of people are speaking a lot more about just the isolation that people feel. In fact, today we had a crisis because the woman slammed down the phone. She said, I don't want to talk unless it's face-to-face. It was to another unit in Journey. So next slide, please. So obviously we know the impact, talked a little bit about that. People are feeling more overwhelmed, more depressed, more isolated, relying more on behaviors and reactions that are more, I want to say automatic, instead of thinking it through and doing some of the healthy coping strategies that you all have worked with your consumers on, that there's an increased negative coping strategies. And then we have some, either feeling like you just don't want to live, you don't want to wake up anymore, kind of passive suicide, to an actual plan. Next slide, please. So I think this is where we need to talk a little bit about an emergency versus a crisis. I'm a very visual person. So a horrific rainstorm is to me, an emergency. A hurricane is a crisis. So a mental health emergency, when by our definition, is the dangerousness that might result in a person dying, someone else getting harmed, or maybe their psychosis or their situation puts them in a dangerous situation. So if you're working with someone with dementia who is wandering from the home in the middle of the night on a crowded road, your home is butted up to 90, 94, or the belt line. So that's how we define crisis. Now, that said, I had a great meeting with APS and Corporation Counsel, and the reality is that Journey Crisis is open 24/7, 365, like police. And sometimes you might say, geez, this doesn't need police involvement, but I just don't know what to do. It's 2 a.m. and we're having a lot of chaos. So we don't ever want to dissuade someone from calling us. But we might be breaking it down a little bit more to whether it's an emergency versus a crisis situation. Next slide, please. My apologies. Actually, the Department of Human Services Statutes 34 actually defines what a crisis is, and you can read that. So when we look at our intervention, we can intervene on a lot of situations. We did a home visit yesterday with someone who basically destroyed his parents' home, was not suicidal, has a diagnosis of schizophrenia. So we intervene, and we spent a good considerable 2 hours with this gentleman and came up with a really good plan and connecting him. So although we have a definition of crisis, it won't always result in an emergency detention, I guess. So crisis is mobile. We go out to homes, we go out to community, meet people out in the streets, into the hospitals. And when we look at a crisis, we can't force hospitalization unless we have a very defined situation. So I worked with someone a couple weeks ago who said this individual is at really high risk for killing themselves. They didn't want to kill themselves that day. They didn't have a specific plan or intent at that time, but they had a lot of risk factors. So crisis isn't likely to do, and that person also has community connections, a psychiatrist, a therapist. So that is something that's good for us to know, but not necessarily something that we're going to be working with in the moment. Next slide, please. So kind of similar, it was interesting looking at Sarah and Leslie's slides. I think we talk a lot about what are some things you can do before it reaches that crisis situation. And you guys are all really good at that and talking about safety plans and response plans. And if you wanted to share them with us, just like with police, so that if we do work with an individual, we can talk in the context for which it might slow a person down, get them to calm down, do some deep breathing. But it doesn't always have to be us for crisis resources. I mean, someone might have an established mental health provider. Sometimes we get calls, a lot of times in the middle of the night, from folks in the community who are really struggling with sleep. It becomes an anxiety provoked reaction. They start dwelling on, kind of their depressive symptoms. But we do have a warm line here in Dane County. We're fortunate enough for that. If there isn't an established provider and you still maybe just need to consult and figure out where to go with this, we welcome your calls. It's always good to know that that's what the call is about. Sometimes it takes our crisis staff a little time to don't mean to be rude, but tell me exactly why you're calling. What are you looking for? How, what direction we should go. We do have some, all of the area hospitals have emergency rooms. Miramont takes people in. They don't have an emergency room, but you can go for an intake. And obviously, if it's such a situation that we can't guarantee the crisis can get there, in a short time, and we know that law enforcement is really fast and can get there. So if it is a life-threatening emergency, we encourage you to call 911. And I borrowed these slides from our director, Hannah Flanagan, and very appropriately, kind of the English major paragraph hook is to another option is a care team. We like to have a continuum of care. Next slide will show a little bit about what Journey can offer. We have community-based programs here at Journey, CSPs, targeted case management, individual therapy. Here in the emergency services continuum of care, we have the CARES team, crisis stabilization, resource bridge, Bayside, recovery house. So a lot of different options offered by Journey. And with that, I think I will pass it to Sarah Henriksen to kind of talk about one of those more recent developments.
Thanks, excuse me. Thank you, Teresa. Welcome, everyone. And I just apologize. I'm getting over a cold, so bear with me here. My name is Sarah Henriksen. I've been a crisis worker at Journey Mental Health for over 20 years. I've been the designated law enforcement liaison for our agency for about 10 plus years, which originally just kind of meant I was the point person for anything related to law enforcement. It was kind of ill-defined or vaguely defined. And then over the years, as our local law enforcement agencies started to kind of really build on this nationwide trend of having folks within their agencies that specialize in focusing on mental health issues in their community, that we saw opportunities for really increased collaboration. And I stress that word so much because it speaks to the heart of what I do. And I've heard Sarah and Leslie and Teresa use that word, and it's the foundation for the CARES program too, which we're going to talk about. But just that we all work in all these different systems that at times can feel really fractured and siloed, and the more that we can do to work collaboratively to understand each other's systems, our limitations and our opportunities for growth, I think benefits everybody that we are trying to serve. So to that end, about almost 6 years ago now, I became the first embedded crisis worker with Madison Police Department. And by the end of the first year, there was a lot of interest in expanding this because we could really quickly see the advantages of having that embedded worker in a law enforcement agency to provide clinical guidance and expertise and that mental health lens for officers. And I know Sarah kind of covered this already, but in terms of the proactive outreach, the responding to active calls for services they occur, all of those kinds of things, and being involved in really just the training and education of officers. So like I assist with the academy every year for the new recruits, and our crisis workers often assist with in services and other kinds of training opportunities for law enforcement. So in May, I became the manager of all of our embedded workers, which we now have 3 at the Madison Police Department, 3 at the Dane County Sheriff. We are also going to be expanding soon to Sun Prairie Police, and our newest program, which is CARES. And this involves a partnership with the Madison Fire Department to have a team of a Journey crisis worker and an MFD community paramedic who can be dispatched from the 911 center to people who are in a behavioral health crisis. And Che's going to share a PowerPoint to kind of explain that a little bit more. But I just want to emphasize again that, this is yet another development that I think we have in this community that really shows the commitment in this community to improving our partnerships and collaboration so that we can respond as effectively as possible to people who are in a crisis, whether those are people suffering from dementia, have an intellectual disability, other types of mental illness, or just having a really crummy day kind of behavioral health crisis. So I will pass it over to Che. Thank you.
Good afternoon, everyone. My name is Che Stedman. I'm the Assistant Chief of Medical Affairs with Madison Fire. I've been with the fire department for 25 years and have been an assistant chief for about the last 6 years. The fire department in 2016 started a community paramedicine program, which essentially was a program to visit folks out in the community in a non-911 situation, folks that are frequent users of the 911 system that have more chronic health problems, low acuity stuff that probably wasn't appropriate for 911 or for an emergency room. And so those folks were specially trained to go out and meet with these customers in their homes to talk to them about healthcare education, refer them to the appropriate social services, and essentially kind of divert people from using emergency rooms that were unnecessary. We also have a program with Meriter Hospital to help case manage 10 of their frequent flyers. So this is a newer program for us, but it was really within the scope of what we do, right? Helping folks understand the medical system. And more recently, at the end of 2020, one of our Common Council members, an Alder, Arvina Martin, approached the fire chief to talk to us about researching an alternate response for mental health crisis. And there's luckily a number of programs around the country that we were able to research and find best practices on. And do you have the PowerPoint available for CARES, or should I share my PowerPoint?
If you wanted to share it, that would be great.
Yep. Do I have share screen ability? One sec. All right. Okay. I believe I need to switch my views. One sec, apologies, I thought you guys had it. So you're seeing the small screen, right? Let me do the regular one.
I can bring that up for you.
Yeah, if you don't mind, I'm sorry, I thought.
No worries.
I've got multiple screens going here.
No worries.
I'm lucky. There we go. Thank you. You can go to the next screen, next slide. So as most of you know, historically, the City of Madison's mental health crisis response, like a lot of cities around the country, have been primarily law enforcement driven. In 2019, when we looked back at Madison Police Department data, we estimated that they received approximately 7,000 calls related to mental health crisis. And so when we were doing research on those national best practices I was talking about, the model that we found to be most patient-centered was one that incorporated unarmed first responders with mental health providers. And specifically, we looked at the CAHOOTS program in Eugene, Oregon, and the STAR program in Denver, Colorado. We were able to get a lot of really good information about what they're doing, how they're evaluating their programs, what they're using for metrics to measure success. And we are very fortunate that not only those two programs, multiple programs around the country have been willing to work with us. So next slide, please. So again, luckily we had support from the mayor's office, and they approved a little over a $500,000 budget for us to start a pilot program for a crisis response team. With the real goal of ensuring that medical and behavioral health care was integrated from the onset of the intervention. So from the time that the 911 call was made, we were getting the right intervention at the right time as early as possible, and hopefully diverting people from emergency departments and jails. Next slide. And so we'll just go through a few slides of some data here. You can see that the average time spent on calls by Madison Police Department officers is about 1 hour for a normal call for service. And for mental health related calls, it was almost 3 hours. We know that the operational stress on the police department around mental health is real. And we were hoping to obviously help them with some of these call types. Next slide. And so looking at the results of the calls for service that the police department went on for behavioral health crisis, you can see that, not a lot of them ended up in some sort of an arrest, a citation, emergency detention. Only a 5% ended up in arrest and 2% in citations and emergency detention. So we saw a big chunk of calls here that hopefully we could intervene on without law enforcement. Next slide. And so our particular intervention was to have a community paramedic from the fire department and a trained crisis worker from Journey Mental Health. Next slide. And of course, this is all about connecting people to services, right? And this is where Journey's role is really important. This is just a short list of some of the resources that we can connect folks with out in the community. But during the whole planning phase, it took us about probably 8 months to get our team up and running. That's including all of the research and getting everything in place and getting people hired and getting all the equipment and the vehicles ready. We were also out, making contact with service providers in the community to make sure that the system that we were setting up was going to be best for our community specifically. Next slide. And so some of the key partnerships that we have, Dane County Human Services was kind of my first phone call, right? And it was mentioned earlier that DHS 34, that administrative code, it says pretty specifically in DHS 34 that each county in the state of Wisconsin has a statutory authority to oversee mobile crisis units. So we worked closely with Dane County Human Services and they contract with Journey Mental Health, right, as their providers. So that's how we got teamed up with Journey. So we have a contract with the county and an MOU with Journey. And so our funds go through the county to help us pay for our Journey crisis workers and also pay a little bit of Sarah's salary for supervision. And then of course the Dane County 911 Center is integral in this whole process because they're the ones that have to triage these calls to our team. When somebody's calling 911, they're going to be getting police, fire, or law enforcement historically, and now we have that fourth resource of a crisis response team, and the 911 Center does a great job of making sure that those calls are triaged appropriately. And really what that means is understanding that it's a behavioral health emergency and also that there's not an element of danger such as weapons or a person making homicidal or suicidal threats. Next slide. And so this, like I said, is a pilot program. We're not running 24/7. We looked back at MPD data and we found that the most common calls came around 11 a.m. to about 8 p.m. That was kind of the largest time frame that calls were happening during the day, and they actually happened Monday through Friday. I was always under the impression that weekends were going to be heaviest for these call types, but I'm going to show you a slide in a second that kind of shows a heat map of when and where calls were happening. And the central district, that central police district was by far kind of had the highest saturation of calls in their district by square mile. So we began our pilot program in the central district. And we're responding out of fire station number 3, which is the fire station on Willie Street. Next slide. And so this is kind of showing some of the data that we looked at over 2 years. You can see the bar graph here. The central district, like I said, was by far the highest amount of calls per district. Next slide. And you'll see some time of day information here. So the heat map across the top again shows kind of all that red is where the most calls are happening during the hours of the day. So that's why our team is responding from 11 a.m. to 7 p.m. to make it an 8-hour day for them. And then you can see in the bottom right here, Monday through Friday was certainly the highest call volume per day. So that was why we chose those 5 days to make it a 40-hour work week for our pilot program. Next slide. And this is our team. We have the 2 community paramedics, Mark and Paco, and our 2 crisis workers, Shaquila and Grace. There's our nice little CARES logo for you, Community Alternative Response Emergency Services. If you all remember that acronym, I'll be very surprised, but that's how we came up with CARES. So I talked very quick. I had a lot of coffee this morning, but I hope that was short and sweet for you, and happy to answer questions in a bit.
Thanks, you guys. Appreciate that overview of Journey Emergency Services and the CARES program. And finally, we're going to hear from Molly Klain, who runs the Behavioral Health Resource Center here at Dane County, and Carrie Simon is going to talk a little bit about a trio center that is in the planning stages. And then the last 15 minutes, we will open it up for questions. And Teresa Fischler has done an all call for questions that we will be able to take in the last 15 minutes. So thanks, and Molly, ahead.
Thanks, Monica. Actually, I will kick us off with a little CTC update, and then I will turn to Molly for some intro to BHRC content. Thanks so much for having us here, this incredible group. It's really inspiring to see so many people coming together on topic and really wanting to be a part of community solutions. So I appreciate all. And I will give you a brief update. Are you seeing just my PowerPoint screen now? Yes. Okay, good. On the Crisis Triage Center. So first of all, I'm Carrie Simon, Community Services Manager with Human Services, covering behavioral health and our newly formed what we call urgent care unit. So I oversee services related to crisis intervention and access points to care, which includes the Behavioral Health Resource Center and some other services we offer. I've been with the department for almost 14 years in my current position since 2018. And it's been a really exciting time to be a part of this part of the world. So just start with a little visual to provide some context. So this graphic sort of represents a very simplified version of a continuum of options that are currently available in the realm of crisis response. So you have a person in crisis at the forefront. Our first line of response is really that 24/7 hotline that Journey runs. And many calls and situations can be resolved over the phone with some supportive services and safety planning. When that is not sufficient to resolve a crisis in the moment, there is the option of a mobile response, also from the Journey Mental Health Center Crisis Unit. They're not able to go out every single time it's requested, but they are able to do a mobile response in the community as often as they can and as often as is clinically indicated. Now, if that mobile response is enough, the CARES team is also a part of that, and that's an exciting expansion to our mobile response capacity. So want to give a shout out to CARES in that space as well. If mobile response isn't enough to resolve a crisis situation, we do have a number of different residential settings that are available in the space of stabilization and diversion, either from hospitalization or from jail or other more restrictive setting. The residential diversion settings have variable capacity, require some screening prior to admission. Everyone who would benefit from having a place to go when they're in crisis would necessarily need to be admitted to a residential facility. So a crisis triage center aims to fill that gap in that it would be a place to go, an immediate place to go for anyone, anytime, when a crisis can't be resolved in place. So in 2021, Dane County partnered with RI International to provide consultation, assessment, analysis, recommendations, develop a plan for the implementation of a crisis triage center here in Dane County. The report and its 14 recommendations reflect the work RI did to study the existing crisis care continuum in Dane County and complete a comparative analysis of the current crisis response system against best practices. You'll see this logo for the Crisis Now model. That's the framework that RI applied as they were looking at our system and making their recommendations. It's also endorsed by the federal level, by SAMHSA. The state of Wisconsin is adopting a lot of elements of this Crisis Now model. So it's a really very solid way to sort of conceptualize the continuum of crisis services. The report recommends an implementation plan for the development of a crisis triage center, and also projects the anticipated impact that will have on the entire crisis response system, and suggests some crisis response redesign that will be required to both address the impact and to optimize the system as a whole. As you see, I have a link here. I can also put that in the chat. The full report is available on our website, and there is a lot of really great information in there. As you can see, there's 14 different recommendations from the RI report. those are both directly related to implementing a crisis triage center and sort of realignment of crisis services accordingly. For today, I'm just going to speak to some of the specifics related to CTC implementation, but I do encourage folks to check out the full report for details on all those related recommendations. So what is a crisis triage center? A crisis triage center is a high-speed assessment, observation, engagement, and stabilization service. It operates 24/7, round the clock, 365 every day of the year. And it has a length of stay of 23 hours or less. So it's not a residential facility. It's really a rapid access assessment and stabilization location from which folks can either be stabilized and safely returned to the community, or that for those who need it, connections to next level of care can be arranged in a safe environment. So this is a medically staffed and flexible observation and stabilization program with recliners instead of beds. So the RI study recommended that for the community of our size and the anticipated activity in a center like this, that we'd need about 22 recliners to maximize the capacity, flexibility, client flow, and the environment. It's medically staffed, so there's a high staffing ratio to ensure that there's clinically appropriate crisis care. And it's a safe home-like environment, not institutional. Guests are treated with dignity and respect, are authentically and meaningfully engaged, and when dysregulated are allowed the space, time, and support to de-escalate. Another really key element of a crisis triage center is a no wrong door approach. And what that means is that they accept all admissions. There is no requirement for medical clearance. There are no exclusionary criteria. This would include folks who might need to detoxify or withdraw from substances, or folks with IDD or other neurocognitive needs. There's really anybody who shows up at a CTC should be able to be helped by that CTC. Which also includes, both voluntary and involuntary options. So what that also means is that it's open to walk-in, drop-off by law enforcement. Individuals could present of their own volition. It might be an option that a mobile crisis response team could transport an individual to a center like this. But it's wide open in terms of availability to whomever under whatever circumstances might be facing that particular situation. Let's see, so they anticipate that there would be about 7,000 admissions annually, and that being diversions from arrest and detention. So trying to avoid having folks need to go to an emergency department or potentially be booked into jail for lack of another option, and really looking for the opportunity to reduce the incidence of hospitalization or other institutional or higher level interventions for folks who might not need it. I mentioned the staff, multidisciplinary. A really key feature that RI talked about a lot was the significant role for peers in a setting like this. So, in an ideal scenario, majority of staff at a crisis triage center would be folks who have lived experience. RI talks a lot about the power of lived experience in de-escalating individuals. That, ideally the first person to greet someone as they walk in the door would be someone who has lived experience, who's been in that situation before. And the last person to see the person out as they are leaving and ensuring connections to care might also be someone who has lived experience. So the concept of a CTC really embraces recovery and trauma-informed care, is looking to offer an option that will help folks stabilize without needing additional support. That said, they do anticipate that roughly 30% of folks who present at the crisis triage center would likely need further stabilization. Whether that be a hospital or essentially an emergency detention or an involuntary commitment, or transfer to a facility like the facilities I mentioned at the beginning of our slide. We do have residential stabilization facilities. And having that buffer of a CTC may really help them better manage sort of the flow of things, maximize the use of those hospital diversion beds that we have in place already. So next steps for us, RI made some really great recommendations on how to approach this implementation, and they identified a number of policy and regulatory challenges related to implementation. So currently we're in the process of gaining some consensus from various partners on the logistics of implementing the recommendations and overcoming those barriers. Some of the major topics that we're really digging into at this point include licensing. This isn't a residential facility, so our crisis residential facilities are licensed under residential DQA guidelines. This wouldn't fit into that. So if it's not a residential facility, how is it licensed? And then in addition, the legal implications of accepting involuntary admissions to a place like this. You know, how would that interplay with things like Chapter 51, our emergency detention laws, and other regulations that might affect the ability to either, you know, allow law enforcement to not have to stay on site for the individuals who might be there on an involuntary status, and the logistics of how, for folks who might need to stay longer than 23 hours, how to, you know, transfer their care to the next level. And then finally, MA billing is a really huge piece of this. You know, there isn't any this operating currently in the state of Wisconsin, although there are many other folks and, you know, at the state, other counties thinking about this topic. So I think we'll really need to get some clarity from our partners at Medicaid and at DHS and other county partners to just sort of, how does this fit into existing MA billing structures, or are there changes that need to be made that would really enable a center like this to become more sustainable? Once we get some of those details ironed out, we will issue an RFP for a provider of CTC services, and we'll begin site selection and preparation alongside with that. Meanwhile, we'll also just be, you know, working with our partners as they are to sort of try to operationalize and conceptualize the ways that the rest of the crisis system will be impacted by the bringing on a CTC, and how we might need to sort of shift the way we are currently operating in anticipation of having this next level of care. I am offered this slide just for, again, a little bit of context. So you heard about the CARES team, increasing mobile response, and the triage center. Both of these initiatives really are targeting the crisis side of the spectrum in terms of an immediate crisis intervention in the moment. Next, you'll hear a little bit more about the Behavioral Health Resource Center from Molly Klein. And that really is an initiative that is more on the preventive side of the spectrum. So I wanted to point that out in this space. It is a crisis services forum, but the BHRC is really there. If someone contacts the BHRC who is in the midst of a crisis, BHRC partners with Journey and their emergency services unit to ensure that that immediate response is in place for an immediate crisis. BHRC is not equipped to be a first responder. And likewise, as folks are sort of receiving stabilization and starting to, you know, stabilize and look at what type of services might help them, you know, continue in their path of recovery or stay stable, the BHRC is an excellent resource to partner on the back end of crises to help folks really understand their options and make informed choices about what kind of care they'd like to get. So with that, I will turn it over to Molly, who can tell you more about the Behavioral Health Resource Center.
Thank you, Carrie. Hi, everyone. Thank you so much for having me here. My name is Molly Klein. I'm the supervisor of the Behavioral Health Resource Center. You can switch the slide, Carrie. And we are a new service here in Dane County, a little over a year old. So just to kind of get us a little bit oriented, the BHRC is a voluntary service designed to help all Dane County residents access mental health and substance use services in Dane County despite insurance status, financial status, age, identity, ability, or legal status. I recognize we're kind of running a little bit low on time, so I'm going to kind of move a little bit quickly. So Carrie, if you wouldn't skip to the next slide, this page just talks a little bit about our founding principles and values. I'd like to highlight the first point, which is to honor and respect the consumer's voice and choice as they seek services. We really value the voluntary nature of our service and highlight what is it that's important to the person as we're seeking out mental health and substance use services with them. Next slide, please. So a couple of slides here that just have some shared definitions. Folks may be comfortable with the term behavioral health. However, we do like to share the SAMHSA definition because it's very in line with the BHRC mission and values. I encourage you to check it out after maybe our presentation, and you can go to the next slide. Peer support is another key component to the BHRC. We have some really strong relationships and contracts that allow BHRC staff to make referrals to peer support and recovery coaching services here in our community. So when someone reaches out to the BHRC, we offer to connect them to the more traditional mental health and substance use services, but also invite them to explore peer support, recovery coaching, group options, wellness services. So we really are trying to look at the person and what they might need in that moment. I've shared some quotes on the bottom too, so you can read, how folks are receiving our services. Another key component is the warm handoff. We're really trying to encourage community agencies and organizations to warm handoff to one another. It really allows for a seamless transition of care. What we mean by that is if I were talking to a consumer and they were expressing some suicidal ideation or they needed a higher level of care than what the BHRC could support them with, we would then call crisis at Journey Mental Health on the phone together. And I would say, hey, this is Molly. I'm here on the phone with Carrie. Carrie's expressing some suicidal ideation. She's got a plan. She's got some intent. I'd like her to get some support from you all. And then the receiving agency, in this case, Journey Mental Health, would then support the person with stabilization. Once they are stabilized, we can certainly help them get back into the process of finding that long-term care. Next slide, please. So who's contacting the BHRC? Most folks that are calling us are consumers, but since opening our doors, we've also learned that there are a lot of folks in the community, professionals, case managers, teachers, school staff, who also would like to consult on the mental health and substance use needs of people they're working with. So that is a really high number of folks who reach out to us as well, and we're happy to support them. We also have a lot of folks who call on behalf of others that they're concerned about. So we call those folks like concerned others, where they might be calling about someone they love, someone they care about, a partner, an adult child, an underage child. And we're happy to connect that person to services that would support the person they're worried about and also them as caregivers, right? So we might make referrals for a caregiver support group or something along those lines. Next slide, please. So when a consumer or anyone reaches out to the BHRC, we have our initial contact. We really kind of try to learn as much as we can and as much as the consumer is willing to share with us. We'll assess the needs, make referrals, and offer ongoing follow-up. Once the person is satisfied with the services they were connected with, we close the case. And you can go to the next slide. So this is a pretty big slide. It's just what we do and what we don't do. I'd like to highlight a couple of things here and then we'll kind of skip to the end. So we provide resource and referral information based on consumer need, provider preferences, their insurance, any barriers to accessing treatment. So we're really trying to connect people to resources. We offer short-term peer support and recovery coaching to consumers who aren't waitlist for services. Again, we offer follow-up as long as it takes. We provide consultation, warm handoffs, and advocacy. Just to highlight a couple of things we don't do, we do not replace any already existing services like CCS service facilitation, hospital discharge planning, or case management services through other programs. We do not provide detailed resource and referral information outside of the scope of mental health and substance use, unless it's an identified barrier to accessing those services. We do not reach out to people of concern. So if Carrie were to call me and say, hey, this is Carrie, I'm really concerned about my neighbor, the BHRC would not call the neighbor on behalf of Carrie's request. And finally, we do not provide crisis services, but as Carrie mentioned, what we try to do is get people connected to resources before they reach that point of crisis. We are trying to get a little bit ahead of the game and get people connected to mental health substance use programming that will meet their needs and hopefully avoid a trip to the ER if that's possible. So you can skip to the next slide. So this is just a little bit of our contact information. Considering the time, I would just highlight the website as a really great place to find information, resources, documents, our mid-year report that we submitted last year. There's just some great information on our website, including how to contact us, and just again reinforcing some of the things I've shared on this presentation today. And you can skip to the next one. And just early feedback we've heard is, folks in the community are really happy to have a place to call and get assistance with getting connected to mental health and substance use services. We really value their privacy. We support them telling us as much or as little as they'd like to, and we'll do our best to get them connected to the services that are most meaningful for them. So I'm happy to answer any questions about the BHRC. I know I kind of flew through that, but we really have found it to be a really fun, dynamic service in our community. The staff are absolutely amazing, and I really appreciate all that you all are doing to both partner and collaborate with us in the community.
Thanks, Molly. I think that concludes our portion of the presentation.
All right. I think, Teresa, do you want to, thank you again, all the presenters, for sharing your information. We're certainly open to any questions you might have at this point. If you want to put them in the chat or that sort of thing, that would be great.
Thank you. Yeah, we've been collecting the questions throughout, so we really appreciate that. And Lynn, I think you were going to get us started with some questions.
Yep. So for the law enforcement, specifically with persons with dementia or IDD, do other police departments within the county have programs or contact people in place so that these preventative steps can happen?
I know
there's-
sorry, Sarah.
Go ahead, Leslie, you got this.
No, we do know that there are several of our law enforcement partners that do have more specified people within their department. The ones around me, I know McFarland, obviously we talked about Sun Prairie. I just contacted one of my Fitchburg contacts earlier this week, referenced someone having some issues. So definitely our partners usually, they might not have a specific established program like Madison does, or have the community deputies, but most of the jurisdictions have a contact person. And I would say the best way to get a hold of them is just to go through the general dispatch number and ask for like a community officer or like a mental health officer in whatever jurisdiction you're looking towards.
Thank you for that. Kind of a follow-up to that is there a practice in place where law enforcement can respond in plain clothes in case the uniform triggers someone?
Yeah, I think there are pros and cons to that for sure. And it's the type of thing where I'm a big proponent of just making sure that our officers are safe and are able to keep citizens as safe as they can. And repetition with our tools is really critical. And when you take an officer who might be used to using their whole uniform and where their tools are, and 99 times out of 100, it's going to be fine to be in your plain clothes, but that one time could be a really critical time. So that's all to say that it's there are a lot of considerations. It's going to be the comfort of each agency and their specific protocols. For the Madison Police Department specifically, we expect our mental health officers to be in full uniform and just to be purposeful about the instances where that might benefit not having the full uniform or having a softer uniform. We just ask that they run that by the supervisor so that we're being really purposeful about safety and balancing that out. So it's a great question and it's something we struggle with, but it's just needs to be purposefully thought out to make sure that we're able to keep people safe.
Great, thank you. I think Teresa has a couple of others.
Yep. Great, thanks so much. So this question relates to safety plan content, and then I think I'll pose it to law enforcement folks and Journey as well. So can you talk a little bit more about what you find particularly helpful or impactful in safety plan content? Many people use a common template, and is there anything that's helpful that would be helpful to have in the plan beyond the standard template information?
For our deputies, the reason we have the template that we showed you is it needs to be clear cut, to the point, one page. We don't, especially in a crisis situation, we don't have a long period of time if we're in the moment to look through a very long one. We want clear, concise. A lot of the information we like is information about weapons, who's in the house, who to contact in an emergency or for the follow-up planning or tweaks of the safety plan. I also really like if it's somebody that I don't know, something super, like I mentioned, something super quick that I can talk to them about. I like to know if they're a veteran. I like to know if they have, even some people really quickly, they have a certain movie that they like. I mean, one gentleman, it was just like Harry Potter, and I just happen to know quite a bit about that. And so it was like an instant thing that I knew to talk to him about. And again, things to stay away from. I have certainly, if it's someone I didn't know that well, made mistakes and started talking about something that really triggered them. And then it was like, okay, I gotta back up and I gotta start over with rapport building. So just really quick, clear, concise things that trigger them, that can develop rapport, and then the safety information. And what my deputies want to know exactly what do they need to do in that emergency. Is this going to be hospital? Is this going to be calming them down and make sure they take their meds for their caregiver and then leave, or what is this going to look like? As much as we can plan out ahead of time. I know different factors can come into play during a call, but yeah.
I would also add that I think one thing I've seen be really helpful in these bulletins is maybe even sometimes something to do before responding. So for example, there may be like a person with IDD who lives in an AFH that has 24/7 caregivers, and they have access to a phone, and they sometimes call 911 reporting an emergency that isn't exactly reflective of what's going on there, and a police response or really any outside response or someone kind of coming in might just escalate things by virtue of having more people involved. And so I've seen a lot of success with some of these plans that say call the caregiver on site before you even come and find out what's actually going on and whether a police response or whatever is needed. And sometimes that alone can be a really effective diversion to having a police contact in the first place.
Great, thank you. I think we'll take we'll pose one more question and then we'll wrap it up. So Carrie, I think this one might be one for you. Will the triage center staff on site be trained specifically in working with persons who have IDD?
Yeah, and there are recommendations in that full report that more fully sort of address this topic. I know where I had a chance to meet with some members of this coalition and hear your input, and that was reflected in the report in a number of places. So there are definitely some recommendations around, how do you want to make sure that your staff and your facility is prepared for the multitude of human issues that will present to you, including specifically what kind of training and mindset can you have around the needs of folks who might present with co-occurring IDD and mental health or other special topiks. So I didn't have a chance to get into all of the details of the report, but I would encourage you all to dig deeper. There's some really good content in there around that too.
Great, Carrie, thank you so much. And I see we're at 1:29, so thank you for all the questions. These are great. We just obviously ran out of time, so we do appreciate you posing them. They're all really, really very thoughtful, and I think I'll turn it back over to Beth and Monica to help us round out the day. Thank you.
And we'd just like to thank you all for coming and presenting and participating. We, as the CSC, are very interested in that intersection of behavioral health and behavioral health crises as it to folks with intellectual and developmental disabilities and dementia. And it's really heartening to see the efforts at collaboration and making space for that. And we are hoping to have a full day in-person seminar training on this topic, and in your evaluation that Michael will be sending you in exchange for your training certificate, we'd love any feedback that you have. And then Beth, do you have any closing?
Yeah. Logistically, I'll just confirm that don't worry about if you were showing on the screen the whole time as Michael Truman, that will not at all impact your ability to get the certificate upon the survey. And then also to follow up on Monica, you know, the Weisman Center through the Community Ties will have some ongoing training posted on their site that is also specific to supporting people with IDD. The coalition is planning a dementia crisis training. We hope on June 9th that we anticipate will be in person, so more information coming. So again, just we appreciate you being here and look forward to future events where we can, you know, again, talk together about all the roles we play in supporting people with IDD and dementia who may face a crisis at some point in their life. So thank you again for. And with that, we hope you all have a good rest of your afternoon.
Thank you for having us.
Thank you.
Thank you, everybody.
Thank you.
Awesome.